Bismillahirrahmanirrahim. Hello friends. Today we will discuss about the cranial nerve examinations. First of all, I will discuss that we have 12 cranial nerves. We have olfactory, optic, oculomotor, trochlear, trigeminal, abducing, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossals. Olfactories come out from the brain via the anterior aspect of the midbrain. Optic come dorsal aspect of the midbrain. Oculomotor, trochlear, trigeminal abducens. Oculomotor and trigeminal come from midbrain. Trigeminal abducen, facial, vestibulocochlear come from the pons, which are parts of the brain stems, and glossopharyngeal, vagus, accessory, hypoglossal come from the medulla, parts of the brain stems. First of all, we will introduce for examination. First of all, we always introduce ourselves to the patients. Hi, my name is Dr. Yarmedi. Can I examine yourself? You, and then after introductions, we will inspect the patients. Positions Position the patient sitting over the edge of the bed. Look for the scar, craniostomy, pupil acuity, facial asymmetry, ptosis, protosis, and neurofibromas. First of all, we will examine the cranial nerve 1, which is olfactory nerve, which control our sense of smell. The first questions for cranial nerve 1 examination is: have you ever noticed any change in sense and smell? If the answer is no, proceed to the next cranial nerve. If the answer is 1, yes, so occlude one nostril, close eye, identify the specimens or the objects you have, like mint and coffee. Insomnia. Loss of sense of smells occur is known as insomnia, like in flu and nasal polyps. We cannot smell. Lesions, nose. If we have lesions in nose, cribriform plates of ethmoidal bone, base of skulls, meningioma, early signs of Parkinson's, we cannot our sense of smell cannot work well. And the second nerve is cranial nerve is optic nerve, which control our visions. First of all, we ask a questions to the patients. Can you see the clock on the wall? For a visual acuity, ask the patient, do they have any difficulty with their visions? Can you see the clock on the wall? Can you read the newspaper? Ask the patient whether she is myopic, like nearsightedness, or hyperopic, farsightedness. Visual acuity. Then we will test for the examine for the visual acuity. Portable nasal chart will enable to perform a more formal test. A patient who is having a visual problem should be asked to count finger. First of all, we will do a senescence test, a chart test. If the patients feel difficulty, so we will ask the patient to count finger held up in front of each eye in turn. If this is not possible, then perception of hand movement should be assessed. Then we will move our hand and ask the patient if he see his hand moving. Failing this, light perception only may be present. If the hand movement is also not working, so we use light perceptions. Visual field. Point the finger point to the moving fingers. Um, Visual fields. Confrontation test. Ask the patient to look in your eye while you place our index finger just outside the outer limits of your temporal field. Move the finger in, turn, and then together. Um, First of all, we will tell the patient that look in my eyes, um, in front of your eyes, like in my eyes. If I am examining the patients, so uh, I I tell my patients to look in my eye, and I take my two hands index finger uh, against the temporal fields and moving. If the and I ask the if I ask the patients, if he see my index finger moving, tell me. In visual intentions, uh, parietal lobe lesion, the patient will only point to one finger when you move both simultaneously. Visual field. Test her peripheral field on each eye separately. Can you see the whole of my face? Like this. Put the one hand on the one eye and ask the, can you feel, uh, can you see my whole face? Yeah, which means that his peripheral, if he see, so his peripheral vision is intact. Visual field. Keep looking at my nose. Tell me when you see my fingers. Visual field. There is another test that we will close one eye of the patients and doctor as well, and take one index finger of one hand, and from periphery to the central we move the fingers, and if the patient, and we will ask the patient, if he see my moving finger, tell me, and we will check their visual field. There is a visual field level of lesions. Blind spots. Tell me when the red pin disappear and reappear. Clear visions, we use Shihara plates for the clear blindness test. Fundoscopy, there is a test of the optic nerve as well, and uh, we will do cranial nerve 3, 4, 6, which control our eyes movements, extraocular movements of the eye muscles. Like oculomotor is supply the superior rectus, inferior rectus, medial rectus, inferior oblique, trochlear, suboblique, um, superior oblique, abducing lateral rectus, and we will uh, check by the commanding the patient to move, to look forward, to look downward, upward, medially, laterally. Oculomotor pupillary light reflex. Direct. Put your hand in between the patient eye with a pocket torch. Shine the light from the side. Do a swinging light reflex. Normally, the pupil into which the light is shown constrict rapidly. Direct light reflex. Simultaneously, the other pupil constrict in the same way. Repeat the procedure on the other side. So, if the pupillary light reflex is uh, in text, uh, RAPD, relative afferent pupillary defect, previous optic neuritis, swinging right test, damaged nerve, dilate in response to light, causes previous optic neuritis. Accommodation reflex. Look at that mark on the wall. Now look at my finger. This is that we will point that look for object and look near object. We see this, the accommodation reflex, that there is blurriness after seeing the far object or not. Look at the mark on the wall. Now look at my finger. Examine the pupil for size, shape, acuity, and regularity. Per, Perla pupil equal, round, uh, reactive to light, and accommodation. There is extraocular movement, assess for eye movement, diplopia, double vision, and nystagmus. Ask the patient to look laterally, left and right. Continue moving the finger to complete edge pattern. Tell the patient to inform you if they see double image. Diplopia. Diplopia is an early sign of ocular muscle weakness. Without moving your head, follow the pin with your eyes. Tell me if he see double. Extraocular movements like lateral rectus, lateral cranial nerve, force supply SO, superior oblique, cranial nerve 6, lateral rectus, cranial nerve 3, supply all others plus levator pupillary superiorlis, which elevate the superior eyelids. There is a third nerve palsy, fourth nerve palsy, and sixth nerve palsy. In third nerve palsy, complete ptosis, eye down and out, dilated pupils, which is not responsive to light and accommodations. Fourth nerve palsy, double vision, going down stair or reading books. Ask patient to turn the eye in and then to look down, may cause vertical hypertropia. Sixth nerve palsy, failure of lateral movement, nystagmus. Nystagmus is the direction of nystagma. Nystagmus is defined as that of fast movement. Vestibular lesion, nystagma away from the side of lesions. Cerebral lesions, nystagma to the side of the lesions. Thank you very much. We will continue the from the trigeminal nerve in the next lectures. Thank you very much.